Dr. Anubhav Goyal. So over to you.
Thank you, Dr. Juhi. So this is 1 hour session on macular neovascularization. First talk is by Dr. Kelvin Teo. CV. Okay. So without 2 hour session. So he is talking on enhancing treatment advance and durability by extending treatment interval in AMD management. So it will be a virtual talk. Sir.
Thank you very much. Thank you for the very kind invitation. And today I'll be talking about enhancing treatment and adherence durability by extending treatment intervals in AMD management. Some standard disclaimers here. Of course, this talk is sponsored by Bayer. So we know that neovascular AMD is a long-term disease that requires consistent treatment. And this is a very nice study, a real-world study done by the Fight Retinal Blindness Group that looked at essentially the rate of lesion reactivation, so AMD lesion reactivation. And what they found here essentially was that if eyes were not treated for 6 or more months, and that's their definition of treatment cessation, 41% would reactivate in 1 year, and a whopping almost 80% would reactivate by 5 years. And if eyes were allowed to reactivate, there would be actually a mean loss of almost 1 line of vision from the time of treatment suspension to the time of treatment restarting. And this really advocates continuous treatment for anti-VEGF therapy, regardless of however long that treatment interval was going to be to maintain good vision. Now, of course, this is tricky, right? Because with AMD treatment burden is high. Essentially, in many places, there are often times where patients have to travel vast distances, or there could be financial issues or other social impact that may prevent continuous treatment with anti-VEGF. So how do we address some of these shortcomings? And one of the ways is actually to look at whether we can use different types, perhaps, of anti-VEGF agents to try to enhance or prolong durability. So I've put up here the current anti-VEGF agents that are available. We have the traditional bevacizumab and ranibizumab. Then, of course, with aflibercept and the newer brolucizumab and faricimab. And one of the ways to think about how these drugs act differently is the concept of binding affinity. So if you look at all those numbers there, if we just concentrate on binding affinity, if we look at the KD value for VEGF-A165, you find that with aflibercept, a good tried and tested drug over the last 10, 12 years, actually its binding affinity for VEGF is the strongest among all agents, much stronger, in fact, than the newer agents that are available in the market. And the idea with this stronger binding affinity potentially then brings about the benefits of improved durability. Now, this is a very nice biochemical study where aqueous humor was sampled in 27 patients. And here you looked at VEGF-A suppression in the aqueous humor in patients using aflibercept. And if you look at where the investigators drew the cutoff line, you see that almost all patients had binding affinity of at least 8 weeks. And the mean duration of VEGF suppression was actually almost 10 weeks. And even if you drew a line at 16 weeks, you can find that a vast majority of patients still exhibited VEGF suppression, even up to 4 months from injection. So having an 8-week cutoff really was very, very conservative for aflibercept. So let's look at some clinical evidence, and let's look at clinical evidence of other anti-VEGF agents such as ranibizumab. Here, they're very well cited treat and extend studies. So TREX can treat Lucas fluid studies. Here, we're all looking at treat and extend regimens. And while treat and extend, a proactive treatment regimen, aims to prolong intervals and reduce number of injections, what you find is actually you're still getting quite a lot of injections using this regimen, and quite a number of patients having to have quite frequent treatment. So the proportion of eyes that had more than 12 weeks intervals was really about 30 to 40% only. And you see over 2 years, you're having injection frequency of almost 16 to 17, even 18 injections. If we look at the data from brolucizumab at week 96, you find that despite the option to extend to 12 weeks, a lot of patients still required more injections, and it was just 1.2 injections fewer than those receiving aflibercept fixed Q8 regimen. So 1.2 injections over 96 weeks. If you ask me, clinically, not very significant. Let's look at some phase 2 data from the faricimab trial. So this is the Avenue study. And if you look at BCVA as well as anatomical outcomes at the phase 2 Avenue study for faricimab, you find that really the endpoints at week 36 were very much overlapping with each other, be it if you're using ranibizumab, faricimab at its various doses. And if we move forwards into the phase 3 trial, the Tenaya and Lucerne trial, you find that almost 30% of patients in the faricimab arm could not be extended beyond the Q8 interval. The other big difference in terms of trial design, of course, was that in the faricimab arm, they required 4 injections. And the idea here was, did you require that 4th injection to get to a steady state with faricimab versus our traditional thinking of 3 loading doses? It's very easy to take top-line results of some of these trials. So be it Hawk and Harrier or Tenaya and Lucerne, really the top-line results there was about extended durability. But as physicians and as scientists, we need to really do a deep dive into the data from some of these trials. And if you look at the claims of durability with faricimab and its advantage over aflibercept, really we have to look at how these trials were designed. And of no fault of the investigators, I think there was a very clear endpoint for faricimab in Tenaya and Lucerne, but it's very difficult to compare durability with faricimab and aflibercept because these eyes were not allowed to have the same extension intervals. So really the evidence for durability, comparing the 2 agents, is difficult to conclude. Now, of course, we all know that there are patients that respond well and patients that don't respond very well. And perhaps some of those eyes from the Tenaya and Lucerne trial that were able to have very good extensions to 16 weeks had not so aggressive disease. And these were some of the review comments by both FDA and EMA about the difficulty in drawing conclusions about the durability of comparing between the 2 groups. Now let's look at aflibercept, tried and tested drug that we've been using for the last decade or so. Also evidence out there about getting patients up to 16 weeks. So here in the Altair phase 4, very much open label. And so the inclusion criteria was arguably a little bit looser. You see almost 45% of patients being able to move up to 16 weeks with aflibercept. And of these patients that were able to move to 16 weeks, a good 96% of them were able to maintain their interval at 16 weeks. Again, with aflibercept, because of its long use, we have very good data on long-term outcomes. And here is the extension studies from the VIEW 1 and 2 cohorts. And you see that vision was really quite well maintained up to 4 years over the extension study period when patients were continued with a proactive dosing regimen. Again, to that point, repetition is a good marker of good science. So you're looking at here evidence from real-world evidence using aflibercept compared to randomized control trial, and you can see with similar treatment regimens from comparing number of injections and vision gain, you find that there's very similar outcomes when used in clinical practice and when used in clinical trial settings. Likewise, here you can see the proportion of patients that were being able to extend out to Q16 and Q12 weeks across clinical trial and real-world evidence. Here you look at data from aflibercept in the use for PCV, something that's very important in our part of the world. A lot of patients having this particular subtype, and you can see that with aflibercept as monotherapy, really gives very similar outcomes to having a rescue PDT. And personally, when I see my patients with PCV, I tend to now start them with aflibercept and find extremely good results using that monotherapy regimen. Similarly, in PCV patients, we are able to extend these patients out, and arguably actually a higher proportion of eyes were able to have longer intervals with this particular subtype. Again, banging home that point where aflibercept you used over the last decade with millions of vials and doses given, we're seeing extremely good low rates of any adverse events and extremely good safety profile for the drug itself. So I'm going to leave this slide here as the summary of what I've been talking about. It's very nice that we have new drugs that are coming into the market to help us treat AMD and even DME. But it is important that we consider and deep dive into some of these trials and the data that it shows us so that we can make informed decisions about what particular agent to give to our patients. Now, I'm going to end with a few case examples. I think this is important, and it really reflects how aflibercept has been used in my clinical practice, at least. The 78-year-old lady here with 660 vision. If you look at the fluorescein, you can see leakage of suggestive of an occult, and on ICG you can actually see the network. And again, I do OCTA routinely for my patients, and you can see very nice a network of new vessels there. On OCT, you can see the pigment epithelial detachment, subretinal fluid, and a bit of subretinal hyperreflective material. I load the patient with 3 aflibercept injections, and with this particular patient, able to extend out 12 weeks. I do repeat angiograms routinely for my patients, and you can see that the activity has dropped significantly from baseline, and this patient was able to extend out to week 16 and maintain at week 16 for quite a number of injections. Really nice, almost normal looking anatomy. Here's another patient starting with 624 vision with a little bit of subretinal fluid. After loading does very well, and so I begin to extend, but some subretinal fluid coming back at 8 weeks. But because of the data from Altair and how we're allowed to maintain some of this subretinal fluid, I continue to extend this patient 12 weeks, a little sliver there, and actually patients doing very, very well. I don't go beyond 12 weeks with patients like this for fear of bad reactivation, but I suppose with vision like this and disease activity like this, it's reasonable to think about pushing this patient up to 16 weeks. Now, here's another one, probably very familiar to many of us, a polypoidal patient, a little bit of subretinal fluid. After loading, does very well, but still a sliver of subretinal fluid. I give 3 more aflibercept, that fluid goes away, and I begin a rapid extension, 4-week intervals to injection every 4 months. And patient doing really well at 16 weeks. What happens, however, at the subsequent 16-week interval is that patient then has a reactivation, so a polypoidal lesion now at the temporal edge. You can see subretinal fluid, you can see some blood on the colors. I give 2 more aflibercept, that comes down, but the sharp peak PED is still present. And so what would you do? Would you, cut it back to 8 weeks? Would you be a bit more intensive with the aflibercept? In this particular case here, I add on some photodynamic therapy with an aflibercept injection, and that seems to settle it down quite nicely. So monotherapy is good, but in some instances, I may opt for adjunct therapy with something else. Last case, if we look at this patient, again, another polypoidal, you can see the large pigment epithelial detachment with hemorrhage. I started this patient with Lucentis, and because the lesion was getting a little bit worse at week 40, I added on some PDT. And you can see that with the PDT, the whole lesion has quietened down. So I allow an extension, but the lesion reactivates. And despite giving almost monthly Eylea injections, that PED is still quite large. At this point, faricimab has come to Singapore. So I've given this patient 2 faricimab injections, but really after even the 2 and subsequent 2 milligram aflibercept injections, the disease still looks fairly similar. So still a large PED with subretinal fluid. At this point, week 100 since baseline, I repeat an angiogram. There's a large polypoidal lesion there. And I'm very fortunate because at this point, so that's an OCTA of the lesion. I'm fortunate because at this point, I am given early access to aflibercept 8 milligram. So I'm sure you'll be hearing about this soon in India. So I give this patient one dose of aflibercept 8 milligram. And if you look at the ICG itself, you can see the lesion has quietened down significantly. The thickness has reduced. Now let's look closely at the OCTs. You can see on the left is pre 8 milligram, on the right is after the 8 milligram injection. You can see that while the subretinal fluid has reduced, the PED after 8 milligram has increased a little bit. But if you look across all other imaging biomarkers, the polypoidal lesion itself and the branching vascular network signified by the double layer sign, you see that some of these markers are indeed getting better with the 8 milligram. And I'm hopeful that with continued injections, I have yet to give this patient his second and third 8 milligram injection. I hope to see this continue to get better. So I'm leaving you here with the OCTA images before the 8 milligram and after. You can see that the entire branching vascular network and polypoidal lesion has really reduced in size and vessel density. Thank you very much for your kind attention. And that's the end of my talk.
Thank you, Dr. Kelvin Teo. Any questions?
Dr. Kelvin, Dr. Girdhar here. Nice talk. What I would like to ask you is, I've not read much about the data on 8 milligram of aflibercept, but what's the possibility of, could that be increased risk of RP, RIP, etc. in patients with a large pigment epithelial detachment because we are injecting more of the drug? Does it increase the risk for RP, RIP? The efficacy may be better, but are there any risks? You couldn't hear? You could hear my question? Yeah, but suddenly his thing has gone. Huh? Can you just set it right?
Thank you. Thank you very much. I think the system didn't let me. No, great question about RPE RIPs. So I don't think there's good evidence actually about whether a stronger agent would cause a higher risk of RPE RIP. My take on this and my hypothesis is that whatever injection that you're giving, and that contraction of the CNV is the reason why there's an RPE RIP. So when you give that injection, whether it is aflibercept 2 milligram or ranibizumab or lizizumab, you're getting the initial contraction, and I think that's when you get the RPE RIP itself. Because if you look at how the biodistribution of anti-VEGF occurs in the eye, you get those peaks anyway with whatever agent you get. So you're getting that maximal effect on the CNV. And I think regardless of agent, you're still going to get that risk of a RIP. Now, then of course, with the higher dosage, you potentially have a prolonged duration. And that's where the higher dose comes in as an advantage. So that's my take on RPE RIPs. It's a hypothesis. So I'm welcome to have, take any other viewpoints on this.
Hi, Kelvin. This is Ken Fong from Malaysia.
Hi, Ken.
How are you? Yeah.
Good, very
So
good.
So really, I think we have reached a ceiling effect with 2 milligram of aflibercept. And I think you pointed out that with the faricimab group, 25% didn't reach that 16-week interval. But conversely, if you look at the aflibercept 2 milligram, it's really less than 30% that can really push to 16 weeks. And I think it's a small group. In reality, with our more than 10 years experience of 2 milligram of aflibercept, really they're getting 8 weeks very safely, 12 weeks maybe some. But in my experience, I don't have anybody on 16 weeks. And so I think the 8 milligram is a step forward. They recognize that's why they need to do that. So I think for the 2 milligram, really we've squeezed whatever amount of visual acuity gain and durability we can from all the different the data that's been real world studies that we've had. I just like to hear your comments on that. Yeah.
I agree. I think with 2 milligram, we have come to a bit of a ceiling, but I do actually have patients that I managed to push out to 16 weeks. Now, I think what the point is here is that we really need to look closely at the inclusion criteria for some of these trials, right? In some trials, perhaps you're getting a larger proportion of eyes that are less active in the beginning, and so you're able to get better durability. In some trials, perhaps you're getting a more varied group of patients that you may not have that same kind of response. But definitely, I mean, over the years, I've definitely had patients go up to 16 weeks. And in fact, some of these I even consider stopping because I think they've quietened down enough. But you know, I am hopeful now with some of these new agents, faricimab, 8 milligram, is really opening up a lot of opportunity for us to treat our patients better.
Thank you, sir. Any more questions?
Hey, Dr. Kelvin, just had a question about like, is there any, when would you not use aflibercept?
When would I not use aflibercept? Good question. So currently, I suppose my thinking would be whether it is a consideration of faricimab versus aflibercept, right? I think with ranibizumab, it is reserved in Singapore at least for patients that is at a financial disadvantage because ranibizumab in Singapore is much cheaper than aflibercept. So that aside, if we look at it from a purely clinical point of view, my comparison would be when would you use aflibercept versus faricimab? My take is that in patients with slightly more chronic looking networks, so your networks are a little bit more mature, I find that in these patients, faricimab tends to work a bit better. So I'm able to get durability with faricimab in these eyes with a bit more mature looking networks. And that's when I might choose faricimab over aflibercept.
Thank you so much. I think that sets the stage for the next talk.
Thank you, sir. Thank you,
Thank
Dr.
you.
Kelvin Teo.
Thank you.
I request Dr. Kenneth Fong to come to the stage for his talk on experiencing the change with Vabysmo in the treatment paradigm for neovascular AMD, evidence from the real world practice.